side. During transport, she had 2 separate episodes. Eyes remained open but fixed with twitching around the mouth and lips. What are you guys' thoughts on what could be going on here? I'd say stroke, absolutely 100% needs to be at the top of the list. I think a stroke alert and transport to Riverside was appropriate.
Neurologic.
Sorry?
Seizure. Something neurologic.
Seizure, yeah.
Head bleed.
Could be a head bleed. I love that. So she was not witnessed, exactly. It's not documented anywhere if anybody witnessed her getting off her bicycle, what happened there. Maybe she did fall off, maybe she got a head bleed. That's what I was thinking reading through this as well, that I think needed to be included in kind of consideration for her. Did initially have some chest pain, not sure how that's related to things. It's not really characterized very well in the report. So I don't know if that's related. But brain is the first thing that comes to my mind. Stroke, bleed, seizure. So she had a history, once they talked to, I think it was the son, of having a seizure in the past that had stroke-like symptoms afterwards. And that's called Todd's paralysis. These Todd's paralyses or Todd's pareses are most common after a focal seizure. So if you have a focal seizure in the right arm, for instance, it's most often to then have a Todd's paralysis of that extremity. So most often they are an extremity. However, there is also a pretty significant portion that can be dysphagia or slurred speech as well. Typical outcomes, it gets better. So after some period of time, it's different person to person, the symptoms go away and it just gets better. So this is another thing that there's no way that you can be able to tell without an MRI and a perfect history and an EEG capturing a seizure and the symptoms improving that it's a Todd's paralysis. So calling a stroke alert and transporting is the most appropriate thing. I guess one question would be, with those episodes of eyes remained open but fixed with twitching around the mouth and lips, 2 separate episodes in transport to Riverside from Worthington, I would think would be less than 15 minutes. So should we consider her as being in status epilepticus and give her benzos as well? I think probably. That being said,
Did it say how long it lasted?
it didn't. That being said, if you're concerned that a patient has a stroke or a brain bleed, not somebody you want to give benzos to and alter their mental status. So, tough balance. Glad I don't have to make that decision today.
Is the etiology similar to Bell's palsy?
Etiology is not really understood.
Okay.
It's thought that there is exhaustion of the neurosystem, the peripheral or central neurosystem, and essentially it's overworked during the seizure and then needs to recover. But that seems pretty made up. And I don't know that there's actually any evidence to support that.
Well, it's just made up.
Does have any questions about this? Comments? Thoughts?
You know the outcome of the found?
Oh, if I remember right, the follow-up was that it was Todd's paralysis.
Yeah. Symptoms completely resolved. And probably needs to be on anti-epileptic medications. If you're having multiple seizures that result in stroke-like symptoms, you're going to need TPA at some point that you don't want.
And rock out right on the bike.
Right.
She was riding, it wasn't our run, but I remember reading the report, she was riding with friends, and all of a sudden she wasn't there. And so they turned around and found her just bending over her bike.
So the biggest takeaway for me was considering head trauma for this patient, because that wasn't really commented on anywhere. I think it just needed to be thought of. Next one was a 40-year-old suicide attempt, intentional overdose about 15 minutes before you guys showed up, of 400 milligrams of Valium. That's a pretty good dose. There was great documentation throughout of vital signs with normal respiratory rate and appropriate oxygen saturation, appears to be able to maintain airway and protect airway at this time. Pupils dilated and slow to respond. There were reassessments, 2 or 3 reassessments throughout that transport that showed that continuing to oxygenate okay. Didn't need to be emergently intubated, but you guys had the stuff ready just in case that was necessary. So what are the concerns with a Valium or benzo overdose?
Mostly respiratory depression and my lack of ability to reverse anything.
Right, period. Exactly. So respiratory depression, respiratory failure, and monitoring, in this case, I think was excellent. So signs and symptoms are respiratory failure, CNS depression, and that's the important ones. As far as treatment goes, it's really just supportive care. Activated charcoal is not indicated for purely benzo overdose, because to give the activated charcoal in a benzo overdose, you want to intubate the patient to protect their airway, and now you've intubated them, so why? Because you've already gotten to the point that you're intubated, so now you can just wait for the benzos to wear off. Flumazenil is a option that we're going to talk about in a couple of minutes as well. But anything else to worry about or that you guys would want to do for this patient?
Got to figure out if she took anything other than the Valium.
Yeah, absolutely, 100%. Because who overdoses on just one thing? I mean, 400 milligrams of Valium, that's not, you're not faking. You're planning on being successful with your suicide attempt today.
Also, previous history, generally, first time isn't the
Yeah,
big time, it's the
Right.
test. So
Right.
probably a significant.
females. Men are
Well,
pretty successful the first
that's
time.
true. They don't usually do pills.
Yeah, also true. So she ended up being admitted into the ICU, continued to be watched overnight, just drowsy, required some fluids because of some hypotension, but never got intubated, was discharged or transferred to a psych hospital the next day.
I don't recognize.
So flumazenil is a benzodiazepine receptor antagonist. Reverses the CNS depression fairly rapidly, so that's great. There are some risks with it though. In somebody who's chronically on benzodiazepines, you would cause an acute and complete benzo withdrawal, which can lead to death. It lowers the seizure threshold very significantly, so any patients who have a history of seizures are on medications that lower seizure threshold or are chronic benzo users, it's contraindicated for. It doesn't reverse the respiratory effects nearly as effectively as the CNS depression, so you can wake the person up and they may still choose to not breathe. It has a bad side effect of causing wide complex tachydysrhythmias and death.
That's a bad
So,
situation.
yeah, I don't give flumazenil to benzo overdoses, and the argument would be nobody should, and really nobody does. It's useful in the benzo-naive patient in basically procedural sedation who gets too much benzo. That's really the only indication that I can think of for flumazenil. Otherwise, intubate the patient.
Does benzo withdrawal look like all other withdrawals? Is it the...
Like alcohol withdrawal.
Okay.
You have tachycardia, hypertension, kind of CNS agitation. So this is a bonus patient. This is a gentleman that I had in the emergency department that actually got the sign out. This was a 34-year-old man who had an episode of maybe syncope, passed out while he was giving a lecture, had a history of hypertension, was on lisinopril. So this was signed out to me as absolutely nothing, basically. He's just going to be discharged once all of his workup is normal. And this was his EKG, and this is why I'm including him now.
This would be the part that's not normal.
So this would be, yeah, not normal. Let's see here. So anything abnormal that anyone wants to comment on? It's wide.
Really
Should be
wide.
wide, yeah. One abnormality.
PDR intervals are definitely extended.
Yes, they are. So this
very
right
regular.
here, with this, is what we call the terminal R wave in AVR. So the QRS complex, with this terminal R wave that kind of goes right into the T wave. And this wide complex QRS with this terminal R wave is classic for a TCA overdose. And that's why I was bringing it up, because of the thought of what else may she have ingested. So she did not have an EKG done. And I would argue that any ingestion should have an EKG done, specifically for this reason. So this guy, he reported only taking lisinopril, but it turned out he also was prescribed nortriptyline. It said he hadn't taken any recently, but I think he was lying to me. So the treatment for
They
TCA...
never lie.
That's right. Treatment. So the problem with TCA overdoses is you get CNS effects and have seizures, and you get cardiac effects, and you go into VTAC and die. So both are not good patient outcomes. So the treatment for a TCA overdose is sodium bicarb. And you give a couple of amps of sodium bicarb, and you watch the QRS complex. And if basically just continue giving sodium bicarb until that QRS complex narrows and returns to normal. So he got 3 amps pretty immediately, and then this was his EKG afterwards. And you can see that terminal R wave is really gone. It still calculates his QRS as 156, but it does not have the same. I don't calculate it that way. It's still seeing like something here as a prolonged QRS. But I calculated it narrower than that, and doesn't have that morphology anymore. And then he got admitted, and then the inpatient team decided not to believe us, and he was discharged the next day. So, 51-year-old gentleman that you saw for acute onset of chest pressure, dizziness, and lightheadedness. And this is his EKG. Any thoughts on his EKG?